Hi, everybody. I'm Dr. Jane Georges from the Hahn School of Nursing at the University of San Diego. Recently, our School of Nursing was asked to speak at the Achievement Rewards for College Scientists, ARCS, annual membership meeting. Our PhD program in nursing science is funded by ARCS scholarships, and we were delighted to take part. They asked us for 3 presentations, one from me, another from a current ARCS scholar who's in our PhD program, Brooke Rakes, and the third from one of our faculty, Dr. Carolyn Etland. Dr. Etland is in fact a past ARCS scholar. She is an inaugural Kay Woltman and Melissa McGuire Hospice and Palliative Care Education and Research Fellow at the Hahn School of Nursing. We've placed these 3 presentations on our website and on our social media sites because we want to express our deep appreciation of all our donors. Thank you for making this once very small nursing school on the beautiful campus on the hill into one of the most cutting-edge, innovative schools in the nation, allowing us to produce the type of compassionate, extraordinary nurses who will revolutionize healthcare. Thank you for joining us.
Good day to you all. I'm Caroline Etland, Associate Professor at the University of San Diego, Hahn School of Nursing and Health Science. I'm also the K.M. Waltman and Melissa R. McGuire Palliative Care and Hospice Fellow in a postdoctoral role. I was an ARCS scholar from 2005 to 2008 as I completed my PhD nursing degree at USD. ARCS support was instrumental in completing my academic studies, and I'm grateful to be able to share some of my work, although I do wish we were together in person. We're living in unusual times, to say the least. During this period of isolation and uncertainty about the future, it's become evident that there has never been a more pressing need for rapid research and good science to guide policy, provide safety, and support the human condition. Some people, including me, believe that palliative care is a global public health concern, as much as an infectious outbreak is. A central question of public health is, how do we safeguard the population from risk and understand the spread and impact of disease? If public health services are intended to respond to urgent, catastrophic need, then palliative care is indeed a global public health issue, and not just for aging populations. By coincidence, I came across this quote from Florence Nightingale a few days ago. It was the anniversary of her 200th birthday on May 12th. It is fitting because 2020 is the year of the nurse and the midwife. She said, "The kingdom of heaven is within, indeed, but we must also create one without, because we're intended to act upon our circumstances." Many essential workers, not only nurses, are acting upon their circumstances as never before. Service to others is the mission. This is clearly a time when compassion and common sense, which we could call the art of nursing, is necessary to guide us through rapidly changing events. My interest in research actually began as a staff nurse on an oncology unit fresh out of nursing school. We collected data for a clinical trial on a new anti-nausea medicine that was a game changer for chemotherapy patients. The drug was Zofran, and it changed everything for patients when, for the first time, debilitating nausea and vomiting was alleviated. Now people could tolerate their treatments, stay on schedule, and have a better chance of being cured. I was hooked on research at that point, and I set a goal of becoming a PhD prepared nurse. I wanted that experience again. Fast forward several decades to 2008. My professional interests were now split equally between oncology and palliative care, which was an emerging medical specialty at that time. For those listening who are unfamiliar with palliative care, simply put, it is simultaneous interdisciplinary care, symptom management, and better communication through conversations about what matters. These conversations are best accomplished with enough medical information about an individual's specific situation, identification of a person's values and beliefs, and a healthcare professional skilled in listening, supporting and clarifying what is said. With my doctoral dissertation, there was an opportunity to advance the science about long-term care residents and identify early warning signs of clinical decline. Using a prognosis calculator, I analyzed nursing home residents for risk of mortality to identify clinical milestones where a conversation should happen and decisions may be made for continued aggressive medical interventions. Prognosis calculators are routinely used for a variety of diseases to help provide information about the coming weeks and months. This is important medical information, so patients and families can make decisions based on their current situation. This is transparency between patient and clinician and builds trust. People may not realize that most of healthcare is actually delivered outside of hospitals, in the community clinics, people's homes, at senior centers, etc. Nurse scientists cannot operate in isolation from their community. A network of colleagues is necessary to identify potential research populations, potential settings, and engage healthcare workers and government leaders to address priority health concerns. About 12 years ago, I had the opportunity to work with the nonprofit Coalition for Compassionate Care of California to implement a new law allowing physicians' orders for life-sustaining treatment, also known as POLST, in San Diego. This was a new kind of document that detailed the conversation between a patient and physician about the patient's wishes for CPR, mechanical ventilation, and artificial nutrition. Regardless of where the patient receives care, this physician's order can be implemented, even if the physician is not on staff at that facility. With a grant from the California Healthcare Foundation, the local affiliate in San Diego contacted each acute care hospital and nursing home, and it was about 65 facilities in all, to train staff and guide development of policies to comply with the law. How significant this document has become in the time of COVID-19, where rapid respiratory decline requires knowing what a patient would want if they cannot speak for themselves. Our local affiliate, the San Diego Coalition for Compassionate Care, has also partnered recently with medical school faculty and students to explore how the students can get additional experience helping patients complete advanced directives via telemedicine while they have some downtime between semesters and they aren't currently allowed back in hospitals. This opportunity will help medical and nursing students beyond graduation throughout their careers, preparing them to identify patients' values, project into the future when health may be bad, and document what is most important to them as individuals. We will be ready to initiate this outreach in the next few weeks. Additionally, colleagues at San Diego State and I have applied for a grant to deliver an advanced care planning intervention to unsheltered people at a downtown nonprofit clinic. Often estranged from family, without regular health care providers, individuals at this clinic rarely have the chance to gain a better understanding of the stage of their disease, diabetes, heart failure, cancer, and be asked what they would want if they can't speak for themselves in an acute illness. This population is most at risk for unresolved, uncontrolled, serious chronic health conditions. As faculty at USD, I also work with a research team to study vulnerable populations and identify community outreach opportunities regarding palliative care. We know that traditionally, some ethnic groups do not access healthcare services as often as many other San Diegans, for a variety of reasons. Both Native American and Chaldean populations are, from a cultural perspective, somewhat closed communities, and it can be challenging to provide preventive timely services, to involve people in research to understand medical decision-making, and to be able to provide palliative care. Needing to understand the scope of several serious illnesses, Dr. Sharon Kepler and I completed a descriptive epidemiology study last year in collaboration with the local healthcare system. We analyzed data on people with advanced heart failure, diabetes, and cancer who were from Native American and Chaldean populations in San Diego. We found that 76% of patients had diabetes, just under 50% had heart failure, and less than 2% used palliative care services. Yet more than 2/3 of the sample requested full resuscitation despite advanced disease status. This is not uncommon. Thinking about the seriousness of these clinical situations, outreach into the community is a priority to understand how to complete advanced directives and provide palliative care. One solution is gentle, persistent outreach. and using the opportunities when people are sick to introduce advanced care planning and palliative care. I've been talking with several palliative care colleagues during the COVID pandemic about their experiences communicating with families remotely to discuss life-sustaining treatment for their loved ones. The process has been emotionally devastating and draining for nurses and physicians. And having these conversations over the phone or the iPad is difficult, to say the least. They have often had to communicate the need for an urgent decision by family members, yet they feel like they're rushing loved ones with a terrible decision that's just never going to feel right. But truth-telling is equally important, so that there is not false hope that the patient who had health problems before COVID might survive this raging illness. I am sure we all wish them continued strength and perseverance with that work. Colleagues at Sharp Healthcare are currently designing a study to measure the impact of the COVID pandemic on frontline caregivers. But advanced care planning doesn't have to be initiated by a physician, a nurse, or a social worker. Families, in our current situation, families are talking more than ever about what they would want if they become critically ill. I've included some resources on the last slide for people to begin or continue that important conversation with their loved ones and their healthcare team. It seems like opportunity is knocking these days. Let's all open the door. In closing, I would like to emphasize that the support provided by ARCS to students absolutely results in science advances that benefit us all, whether through staying well during a pandemic, designing environments that resist pathogens, or understanding how to talk with each other about things that are hard to say. In all cases, honesty and transparency will not only get the job done, we will feel better for having tackled a difficult conversation and told our truth about what matters most. Thank you again, and stay well.